Welcome to the deep dive. So let's picture this. You have a patient with Parkinson's disease. They're already dealing with, tremors, stiffness, tough motor symptoms.
Right.
And then they end up in the hospital for something totally different, maybe an infection, something acute.
Happens all the time.
But now, because they're sick or maybe the Parkinson's itself is flaring up, they suddenly can't swallow their meds.
And not just any meds.
Exactly. We're talking levodopa, carbidopa. It's the cornerstone treatment, isn't it? The absolute essential for managing those symptoms.
It really is. Missing even a single dose can be a huge problem. They can go into a severe off state.
Which makes everything worse, including, potentially, the swallowing problem that started it all. A real vicious cycle.
It's a major clinical headache. Levodopa is critical, but if you can't give it orally, your options suddenly become, well, pretty limited. Especially in a hospital where you might not have all the fancy formulations on hand.
And that, right there, is what we're diving into today. We've got this really interesting case report. It looks at a surprisingly simple, maybe even a bit unconventional, approach they tried when basically all the standard doors were closed.
Yeah, they tried giving crushed levodopa carbidopa under the tongue, sublingually.
Kind of creative, yeah.
Yeah.
Born out of, well, necessity.
Definitely a tough spot situation.
So our mission today, unpack this case. We'll look at the patient, the exact problem they were facing, this novel method they attempted, what actually happened, and maybe most importantly, what it could mean for handling these really tricky situations.
Sounds good. Let's dig in.
Okay, so first, let's just reinforce the challenge. Why is oral levodopa-carbidopa so vital, and why is losing that route such a big issue?
Well, levodopa is essentially how we replenish dopamine in the brain for Parkinson's. But levodopa on its own gets broken down pretty quickly in the body before it reaches the brain.
That's where carbidopa comes in.
Exactly. Carbidopa acts like a bodyguard. It inhibits the enzyme that breaks down levodopa peripherally outside the brain, so more levodopa actually gets to the brain where it's needed, and you get fewer side effects like nausea elsewhere. It's fundamental.
And dysphagia, the swallowing difficulty, you mentioned it's common?
Incredibly common. The report cites up to 80% of Parkinson's patients experience it at some point.
80%?
Yeah. So when that happens, or if a patient is just too unwell to take anything by mouth, their main treatment is suddenly cut off.
Leading to worse Parkinson's symptoms.
Right, potentially making the swallowing even harder, like you said, that cycle.
So you absolutely need another way in. The report touches on alternatives. What about rectal administration? Seems like an obvious backup.
You'd think so, but the evidence cited suggests it's, well, generally not very effective for levodopa. There was an older study, back in '81, where they couldn't even detect levodopa in the blood after giving it rectally. Patients didn't improve clinically.
No effect at all.
And another study showed the plasma levels achieved were just tiny compared to oral doses, like really tiny. The report mentions maybe 17 nanomoles per liter rectally versus, 1,400 up to 12,000 nanomoles per liter orally.
Wow. Okay. That's not just a little difference. That's negligible almost. Why so poor?
Absorption rectally is just known to be really erratic and inefficient for many drugs, including levodopa, apparently. There's limited surface area compared to the gut, and the drug might interact with fecal matter or mucus. It just doesn't get absorbed reliably.
Not a dependable route, then. What about other non-oral options? Things like orally disintegrating tablets or the newer subcutaneous infusions, enteral gels.
Those are definitely effective non-oral strategies, yes. But the issue, as the report highlights, is often access and cost, especially in an acute setting like the ED.
It might just not be on the hospital formulary or readily available.
Exactly. Or they might be expensive or require specific equipment or training. So the doctor in the ER, facing this patient who can't swallow and knowing rectal is probably useless, they might suddenly find they have no standard non-oral dopamine replacement immediately available.
Which brings us right to this specific case. Tell us about the patient.
Okay, so this was an 85-year-old man. He was admitted to the ED from his long-term care facility. His diagnosis was Lewy body dementia.
Which often includes Parkinsonism, right?
Yeah.
So he needed the levodopa.
Precisely. He needed levodopa carbidopa for his motor symptoms.
And he didn't come in because of the Parkinsonism initially?
No, he presented with confusion, altered consciousness. They figured out pretty quickly it was due to a UTI, a urinary tract infection, and also acute kidney injury.
Okay. But the critical part for the story is that because he was confused and unwell.
He couldn't take his meds. He missed his scheduled dose of immediate-release levodopa carbidopa. His usual was 125 milligrams 3 times a day.
And how long had it been since his last dose when this all went down?
The report states about 4 hours past his scheduled time, and missing that dose, plus being unable to take the next one orally because of his condition, it just sent him spiraling into a really severe off period.
What did that look like? What symptoms were they seeing?
Markedly worsened Parkinsonism. They specifically noted quite pronounced resting tremors, both hands, maybe around 2 cycles per second, significant body rigidity too, and crucially, his swallowing difficulty, his dysphagia, had also gotten much worse.
Ah, so the missed dose worsened the very symptom preventing him from taking the dose.
Exactly that cycle again. And interestingly, the report notes his family actually already had a routine of crushing his pills at home.
Oh, really? Why?
Because he already had some baseline swallowing issues. They mixed the powder with food. So crushing the tablet itself wasn't totally new territory for him.
But the route they were about to try definitely was.
Mm-hmm.
And just to confirm, why no rectal attempt here?
2 reasons given. 1, it had apparently been tried before for him and didn't work. And 2, the family voiced concerns about it causing him embarrassment or distress, mentioning his preference for modesty.
Okay, so clinical ineffectiveness and patient family preference ruled it out.
Right. So there they are. Can't take it orally. Rectal is out. No other standard non-oral options immediately available in the ED formulary.
That's the dilemma, plain and simple. Urgent need, worsening symptoms, standard options exhausted.
They had to think outside the box and quickly.
So what was the move? What did they decide?
Facing this pressure and the lack of standard alternatives, the team did something pretty unconventional for levodopa carbidopa. They took one of his immediate release tablets, crushed it up into a fine powder.
Like the family did at home.
Right, but instead of mixing it with food, they administered it sublingually, placed it right under his tongue.
Okay, were they confident this would work? Was there precedent?
Not really, and the report is upfront about that. Sublingual isn't a typical or validated route for this drug. It sounds like it was very much a decision made out of, clinical urgency and just not having other options right then and there.
Okay, this is the crucial part. They put the crushed powder under his tongue. What happened next?
This is where it gets really interesting. According to the report documented by the nurse, confirmed by his family, they saw a significant symptom improvement within about 2 hours of giving that sublingual dose.
2 hours?
Yeah.
That's actually quite quick. Similar to what you might expect from an oral dose, if you could take it.
It is, and the reported improvements were pretty striking. His hand tremors, which were really obvious on arrival, around 2 hertz, they became barely noticeable.
Wow.
His upper limb rigidity also decreased significantly. And maybe most functionally relevant, he was actually able to voluntarily lift his right arm above his chest level, which he couldn't do at all when he first came in.
Okay, even if those are subjective observations by the nurse and family, that sounds like a clinically meaningful improvement for someone deep in an off state.
It definitely seemed consistent with him returning towards his usual baseline motor function, according to the people who knew him.
What happened after that? Did he get better overall?
Yes, his underlying issues improved. His confusion cleared up within 24 hours once they started antibiotics for the UTI.
And once he was less confused.
He could participate in a swallowing assessment, and he passed it.
Great. So he could go back to his normal meds.
Exactly. He restarted his usual dysphagia diet and his regular oral levodopa schedule. And the report mentions he's still tremor-free and mentally clear over the next couple of days. So the crisis passed, and his standard treatment worked again once he could take it.
It really sounds like this unconventional sublingual dose acted as a crucial bridge, didn't it? Got him through that awful off period until the underlying problem resolved.
That's certainly what the case report suggests. It appeared to work in this one specific high-pressure situation.
Okay, let's switch gears a bit to the science. The authors talk about why this might have worked, but they also mention that, theoretically, levodopa shouldn't be absorbed well under the tongue. Why not?
Yeah, it comes down to the drug's chemical properties. Levodopa is described as hydrophilic. It likes water. It has low lipophilicity, doesn't like fats or lipids. It's polar, and it exists as a switarion at the body's pH, meaning it has both positive and negative charges.
And why do those properties make sublingual absorption difficult?
Well, think about the membrane under your tongue. Like all cell membranes, it's largely made of lipids, fats. For a drug to easily pass across that fatty barrier just by simple passive diffusion, it generally needs to be somewhat lipid-soluble, lipophilic.
So something water-loving and charged, like levodopa, has a hard time just slipping through that fatty layer on its own.
Pretty much. It's not ideally suited for passive diffusion across a lipid membrane.
Okay, so theory says difficult, but observation says it seemed to work. How do the authors try to reconcile that? What are the potential explanations?
They offer a few key points. First, that area under the tongue, the sublingual mucosa, is extremely rich in blood vessels, very vascularized, right close to the surface.
All right.
So even if passive diffusion isn't great due to the drug's chemistry, that dense network of capillaries provides a large surface area for whatever can get across to be quickly whisked away into the bloodstream. Maybe other transport mechanisms are involved too, not just simple diffusion.
And a big advantage of absorption there is bypassing the liver initially.
Right, exactly. When you swallow a pill, it goes through the gut wall and then straight to the liver via the portal vein. A lot of levodopa gets broken down there. That's called first-pass metabolism. Absorption under the tongue goes directly into the systemic circulation, avoiding that initial hit by the liver.
So potentially more of the absorbed drug reaches the rest of the body, including the brain, intact.
That's the idea. Bypassing first pass is a potential benefit.
Okay, so high vascularity, bypassing the liver. What else might have helped in this case?
They also mention the high local drug concentration they created by putting the crushed powder right there. Plus, the patient likely had prolonged contact between the powder and the mucosal surface.
Just letting it sit there dissolve. Yeah.
Right. That combination of high concentration and extended contact time might have helped drive some absorption, even if the process isn't super efficient. And, of course, crushing the tablet dramatically increased the surface area of the drug available for contact.
Makes sense. And then there's this other point they make, which feels really key from a practical standpoint. You might not need perfect absorption to get a result in this situation.
Yes, this is probably the most critical clinical insight in their discussion. They argue that for a patient who is severely off, meaning their dopamine levels are really low because they've missed doses, you don't necessarily need to achieve the same high peak drug levels as a normal oral dose to see a significant clinical improvement.
So just getting some levodopa back into the system might be enough to bump them out of that severe state.
That's the hypothesis. Even a relatively small increase in plasma levodopa, perhaps from partial sublingual absorption, could be enough to provide meaningful symptom relief when you're starting from such a low baseline. It might bridge the gap.
That's a really interesting point. Did they also consider maybe he just accidentally swallowed some of it?
They do acknowledge that possibility, yes. Some of the powder placed under the tongue might have mixed with saliva and been swallowed, leading to some delayed absorption through the usual gut route, which could have contributed to the overall effect they saw. Hard to know how much, though.
Did the authors find any other reports like this in the literature? Anyone else trying sublingual levodopa?
They found one previous publication, a case series involving just 2 patients, but it was used differently.
How so?
In that series, they used sublingual crushed levodopa carbidopa prophylactically to prevent Parkinsonian symptoms from worsening around the time of surgery, when patients couldn't take anything orally beforehand.
So maintaining control, not rescuing from an active off state.
Exactly. This new case report seems to be the first one published showing this technique being used successfully to actually treat active, severe off symptoms.
Okay. Now, it's important to talk limitations. What did the authors themselves point out?
They're quite clear about them. First, it's a single case, just one patient. Second, it's purely observational that they just described what happened, wasn't a controlled experiment. And maybe most importantly, there was no objective pharmacokinetic data.
Meaning they didn't actually measure the levodopa levels in his blood after the sublingual dose.
Correct. So while they saw a clinical response, we don't have hard proof of how much drug got absorbed or how quickly or how reliably this method might work for anyone else.
So consistency, reliability. Big question marks remain.
Absolutely. Based on just this one observation, those are uncertain.
Okay, let's try and synthesize this. Given the observation, the theory, the limitations, what's the main takeaway message from the authors?
Their bottom line is that sublingual administration of crushed immediate-release levodopa carbidopa is a potential alternative route.
Potential. Not standard practice yet.
Definitely not. And they stress it's for very specific situations. Basically, when a patient cannot take meds orally, and the standard non-oral options, things like patches, injections, gels, are unavailable or maybe inaccessible due to cost or formulary issues, or perhaps not acceptable to the patient, like the rectal wrap wasn't here.
So it's framed more as a practical, maybe even pragmatic workaround. something you could actually do in a pinch when other doors are closed.
Exactly. A readily implementable option using what's usually available, the standard tablets, but they label it clearly as exploratory at this stage.
And what needs to happen before anyone could consider this more routinely?
Oh, much more research. Proper studies are needed to really figure out if it's reliable across different people, to actually measure the absorption, the pharmacokinetics, figure out the right dosing for this route, and understand its place, if any, in broader clinical practice.
But still, the fact that they saw any benefit in this case is pretty compelling, isn't it? It suggests this very simple technique might offer a way to help patients avoid those dangerous complications of severe off states when they're hospitalized and miss doses.
It really does highlight a potential stopgap, a bridge solution, when the ideal treatments just aren't an option in that moment.
Okay, so wrapping up this deep dive, we looked at a case report that really zeroed in on a tough problem in Parkinson's care.
Sure.
What do you do when patients desperately need their levodopa carbidopa but can't swallow, and the usual non-oral backups aren't available?
Right, and this report described one instance where a method that seems unlikely on paper, crushing the tablet and putting it under the tongue, actually appeared to provide real, timely clinical benefit for a patient stuck in a severe off state.
Yeah, even though the theory of absorption is tricky and it's just one case without blood level data, the result they saw was intriguing. It hints that maybe, just maybe, getting even a small amount of drug absorbed through that highly vascular area under the tongue, bypassing the liver first, could be enough to make a difference when someone's levels are critically low.
It's definitely not being pushed as a new standard, not yet anyway, but it is presented as a potential practical tool for that very specific, difficult clinical moment.
It really makes you think, doesn't it, about how sometimes these simple, low-tech adaptations, things born out of pure necessity when the ideal stuff isn't around, might actually offer temporary lifelines in complex situations.
It certainly does, and it leaves us with a thought to ponder. How could we better explore or validate these kinds of practical, readily available workarounds? Could they help more patients when the perfect solution just isn't within reach?
Something definitely worth thinking about. Thanks for joining us for this fascinating deep dive today.